So the main aim of vital pulse therapy is to preserve and maintain the pulse tissue in a healthy state, and its objective is to stimulate the formation of reparative dentine to retain the tooth as a functional unit. The different pulse therapies are indirect pulse capping, direct pulse capping, pulpotomy and apexogenesis, which definitely become vital pulse therapy. The non-vital therapy can be apexogenesis and pulpotomy, and now we have regeneration also, right? So what are the different things? Let's look at that. Now, here you can see we've got in reversible pulpitis, you can do vital pulse therapy like pulse capping or pulpotomy. But in irreversible pulpitis, if it's a closed apex, no vital pulse therapy, root canal. But in open apex, you might have to do apexogenesis or apexogensis, right? So let's look at indirect pulse capping. It is defined as a procedure wherein a small amount of caries dentine is deliberately retained in deep caries areas of cavity preparation to avoid exposure of the pulp. So you never expose the pulp in indirect pulse capping. And then you place a medicament so as to permit healing. So it arrests the carious process, it promotes dentinal sclerosis, it stimulates the formation of tertiary dentine, and it remineralizes the caries. You have to take proper history. There should be no history of pain, good clinical examination. There can be a large caries lesion. The vitality test should be done and the tooth should be vital. Radiographically see that the pulp has not gone, the decay has not gone into the pulp, and the periapical picture is clear and normal. If there is a lot of pain in the night, if there is discoloration of mobility in the tooth, or if there is a large radiographic lesion, this is contraindicated. The materials used for indirect pulse capping are calcium hydroxide, glass ionomers, dentine bonding agents, biodentine, endosequence root repair material, and calcium enriched mixture. These are the few materials that you can use. So you need to know the components of each one and the constituents of each one of them. The next is direct pulse capping. Direct pulse capping is defined as the protection of a pulse exposed mechanically during removal of caries. The thing is, there is a small pinpoint exposure. Instead of going in for a root canal or anything more, you try isolate the tooth totally and at once seal that exposure site with a specific medicament like calcium hydroxide or MCA, such that the tooth comes back to normalcy. So if there is a small mechanical exposure, the diameter of exposure is less than 1 millimeter, or the exposure should be bright red emerald that can be easily controlled by a cotton pellet with minimal exposure. The contraindication is if there is severe toothache at night, if there is spontaneous pain, or there is tooth mobility or thickening of the periodontal ligament base, or radiographic there is evidence of pulpal and periapical degeneration. Again, the materials used can be any of these: calcium hydroxide, dentine bonding agents, MCA, lasers, DMP, and biodentine. Then we come to pulpotomy. Now, pulpotomy is defined, this definition is very important, as the amputation of a damaged, inflamed, or removal of the damaged, inflamed vital pulp from the coronal chamber, followed by placement of a medicament over the radicular pulse ducts to stimulate repair, fixation, or mummification of the remaining vital radicular pulp. So pulpotomy is defined as amputation of the affected and infected coronal pulp and preservation of the radicular pulp vitality. How do you do this? Very simple. Main thing is you preserve the vitality of the pulp, remove the infected and inflamed pulp, maintain it in good physiological condition such that the radicular pulp is healthy. The different ways of techniques or classifications are: you do a devitalization pulpotomy, which can be pharmacosol, electrosurgical, or laser. You do a preservation pulpotomy, that is glutaraldehyde ferric sulfate, a regeneration inductive or reparative one, that is with calcium hydroxide or bone morphogenic protein, or you do, depending on the size of exposure, a specs pulpotomy or a cervical pulpotomy, and depending on the number of visits, a single visit or a multiple visit. If you open Grossman, you will get all these things in detail. These are the indications when there is a mechanically exposed vital. The thing is, you take out the coronal portion of the pulp, put in a medicament, and see that the rest of the vitality of the pulp is maintained. That is very important. The caries exposure in vital asymptomatic primary teeth. In the treatment of pulpally involved primary teeth with clinical manifestation of inflammation, and in the treatment of pulpally involved permanent teeth with open apices, and in the treatment of fractured permanent teeth with pulp exposure is greater. The contraindication of sudden spontaneous pain, abnormal sensitivity to hot and cold, the tenderness to percussion, there is swelling, sinus, pus, mobility, uncontrolled hemorrhage. There is external resorption seen in the X-rays. If there is a large periapical radiolucency or internal root resorption of pulp calcification, pulpotomy is contraindicated. So I think I have done it well in time. A little bit about Apexogenesis is a term defined to preserve vital pulp tissue in the apical part of a root canal in order to complete formation of the root apex. This terminology is vital pulp therapy and is defined as treatment of a vital pulp in an immature tooth to permit continued dentine formation and apical closure. Right? This is how you have a wide open apex. The tooth is vital. You can use different calcium hydroxide or MTA and try and stimulate closure of the apex with this vital remaining pulp.